Hello and welcome to Treatment Resistant Depression, presented by Monterey Behavioral Health with our own in-house medical director, Jonathan E. Shaywitz, MD. And we're going to do a little housekeeping before we turn it over to him for the part that you're most excited about. Uh, First of all, we're really, really excited at Monterey Behavioral Health that we are going to host one of the first West Coast behavioral health conferences, and it's going to be next February 24th to the 25th. So take out your day timers now and mark off those dates for yourself. And it's going to be held in LA, somewhere really prestigious and fun. So save those dates. And also, if you're on this mailing list and you signed up, we will be sending out a call for proposals soon. So if you know anyone who's leading the way forward in trends for behavioral health, let us know. We're specifically going to be looking for eating disorders, young adults, and also new modalities, evidence-based modalities in treatment. In order to get your CEs for this event, the Zoom records you. So you will need to stay through the end and fill out your evaluation form, and then your CE will come right in your email. And another special thing is that stay till the end, and then Monica Montoya will come back on, and she will uh, offer up lunch in your office for being able to answer questions that if you pay specific attention to Dr. Shaywitz. I'm going to tell you a little bit about Monterey Behavioral Health, and we are a family of treatment centers dedicated to changing the landscape of mental health recovery. We provide comprehensive, sophisticated mental health treatment throughout Southern California. We specialize in treating disorders such as depression, anxiety, trauma, PTSD, personality disorders, schizoaffective disorders, and bipolar disorder. We take a fresh, innovative treatment approach, incorporating cutting edge therapies with a holistic philosophy. We view success not only in the prism of crisis intervention, but rather in the larger context of happiness and prosperity. And if you were listening, Monica was correct. We are always looking for good partners because, in as we all know, in behavioral health, it's not a one and done. People need consistent, ongoing care. And so, where we might provide the answer this time, you may be the next best practitioner for the next time or for a continuum of care. So, make sure you reach out to one of us at Monterey. And my name is Renee Barrow, and I do marketing and outreach. I'm the conference coordinator, and I'm in charge of hosting these events and doing our podcast. So if you know a great guest for our podcast who treats one of those disorders that I just told you about, please feel free to reach out to me as well. And then uh, Monica is going to be monitoring the chat. She's going to be sending it out to everybody who's put their name in there at the very end. So make sure you add it to the chat. But if you have a question for Dr. Shaywitz, please put it in the Q&A, and we will answer it. I see that somebody wants to know that Monterey treats adults at this point, not adolescents. And we will be opening an eating disorder program soon and a specialized trauma uh, center for women. So we've got a lot going on, and you're going to learn about some of the newer modalities that we've incorporated into our treatment. Without further ado, I want to introduce you to our own uh, medical director, Dr. Shaywitz, who's a board certified psychiatrist. He received his BA with honors from Brown University and received his medical degree from Harvard Medical School. He has completed his residency at UCLA, where he was selected chief resident for the anxiety disorder program. Dr. Shaywitz was the director of anxiety disorders programs at Cedars-Sinai, the medical director at Glendale Memorial Hospital, the medical director in behavioral health at Mission Hospital Laguna Beach and Mission Hospital Mission Viejo, and medical director at La Casa Psychiatric Facility. He was the director of practice development for the community psychiatry. He was awarded the Circle of Friends honor at Cedars-Sinai and has published book chapters and journal articles on treatment of behavioral health disorders, and is particularly interested in anxiety disorders and affective disorders. He has completed a fellowship at MIMH and Columbia University. He is also co-authored of the second edition of the best-selling book published by Knopf, Overcoming Dyslexia. I mean, that is just such a list of honors, Dr. Shaywitz, and we are really, really excited to have you as part of our team and so willing to share your wisdom and information with people. So welcome.
Thank you so much, Renee, and it's been such a pleasure to be part of the Monterey team. Today, I'm going to be talking about treatment-resistant depression and some of the newer modalities that help with the TRD, as we call it. Before talking about the newer modalities, I think it is really important to understand about depression itself. Major depression is a disorder that affects over 17 million people, and it affects which is about 10% of the population. What's more interesting is that the remission rates are so low. So individuals who are treated with MDD, who have MDD, often about a third of those folks are still not fully treated. So I think what's really helpful is to start from the beginning, in a sense, and look at major depressive disorder, talk about some of the newer and the algorithm that we use as clinicians, and that's evidence-based to treat major depressive disorder, and then talk a little bit about the newer modalities such as ketamine and transcranial magnetic stimulation. So next slide. So I wanted to talk a little bit before talking about depression. We want to make sure that everyone is all on board with what are the criteria for major depressive disorder. And so I think, as many of us know, that it has to be 5 or more of the following symptoms that are present during a same 2-week period. Could we go back, Renee? Yeah. Depressed mood most of the day, nearly every day. Diminished interest or pleasure in almost all activities most of the day. Significant weight loss or weight gain. Insomnia or hypersomnia nearly every day. Next slide. Psychomotor agitation or retardation, loss of energy, feelings of worthlessness or guilt, inability to concentrate nearly every day, recurrent thoughts of wanting to harm oneself. And that what's very important is that these symptoms cause a significant distress or impairment in everyday functioning. Next slide. And also that's very important is that these symptoms are not attributable to a medical condition or physiological effect from a substance use. And also there's never been a manic or hypomanic episode. So, when we talk about major depression, depressive disorder, and TRD, it's important to first understand this is a criteria that, that we're referring to. Okay, next slide. So I wanted to give a little bit of a kind of a video here on depression, which I think will be helpful as well. Great. So that was, I think, a good video really showing a little bit about depicting what an individual who really is suffering from depression is going through on a daily basis. And so, kind of segueing into individuals that have treatment-resistant depression, before going into that, we need to figure out how do we define treatment-resistant depression? And it's really interesting because look, for the last 30 or 40 years, there's been about 11 or 12 different definitions that have described treatment-resistant depression. So the answer is there's no consensus on a standardized definition of treatment-resistant depression. And what commonly is used is major depressive episodes that do not respond satisfactorily to 2 trials of antidepressant monotherapy. But this is interesting because it has a lot of significance because there's no standardized definition in terms of how neurobiological underpinnings, how do we define that for studies, how does insurance decide whether these new modalities are going to be approved or not. And it's very interesting, Dr. Conway in JAMA article in 2017 talked about this, and really I thought summed it up very nicely, saying this lack of consensus, quote, limits the ability to do comparative treatment research to understand the biological underpinnings of treatment-resistant depression and produces ambiguous medical insurance coverage issues. This was actually further supported by Dr. Wang, who is the APA Director of Research, who also stated that without an agreed upon definition of TRD, different payors are going to be using different criteria to determine what they will reimburse for. And ideally, you should have a uniform definition so that insurance coverage would be more consistent. And again, I think this is something we face on a daily basis when we're trying to get individuals approved for either one of those newer modalities, whether it be Spravato or TMS. So, there's been, like I said, 11 or 12 different studies. Next slide. And this is a good summary from BMC in 2018, really summing up all the different definitions of treatment-resistant and depression. And you can see, going back to 1974, looking at defining it from a failure of a dose of imipramine for 4 weeks. Then in 1997, Michael THASE and Rush looked at defining it by a failure of one adequately given depressant medication. Then Surianol, which is really now thought of as a European model, described it as 2 antidepressant medications from different classes. You can see in 2003, the MGH is looking at a failure of one antidepressant medication and looking at different stages. So in looking at these, you can see that it started out with a specific medication, imipramine, given for a certain amount of time and failure of that. Another one looking at, again, a failure of one class of medication, failure of 2 classes of medications, failure of medications within a class, failure of medications in separate classes. And this is really kind of going back to the previous slide. There is no standardized consensus, and that in terms of how things are approved from insurance, it's a little bit of a challenge because there is not that one definition that is able to be used. So, there's folks that some insurance companies approve it with one antidepressant or 2 antidepressants from one class, and another insurance company will approve these newer modalities, but it has to be from 2 different classes. So there is no general consensus on that, but this is a slide that really kind of gives a nice background about the evolution and of the different definitions of how one can define treatment-resistant depression. Next slide. This is one I just wanted to emphasize. This is THASE, Michael THASE, who's really one of the gurus on defining treatment-resistant depression. Stage 1, this is from THASE and Rush, looking at one adequate trial of an antidepressant monotherapy. Then he describes stage 2 as that stage 1 plus a different antidepressant class. And then down the road, it's a tricyclic and MAOI, which are different types of medications. A tricyclic is one of the initial antidepressant medications before the arrival of SSRIs. MAOIs are even more older medications. And then, of course, the stage 4 is failure of ECT course. So plus the stage 4. So this is something, a type of a stage that's also commonly used. So I just wanted to emphasize that as well. Next slide.
Dr. Shea, would you have a question? Do you want me to save them up? It's about this section. Or do you want to answer it now or go for me to come back to that?
Why don't we try to do it at the end? How's that?
That's good. All right. So we'll answer questions at the end, everyone. Perfect. Okay.
So what do we have? We have what a major depressive episode is from the DSM-5. We have that there is no consensus definition, but we also see that it's an evolving set of definitions going all the way back to 1974. So if someone is in any of these definitions considered to have treatment-resistant depression, are there risk factors that can cause this? And there are, and some of them are listed here. These are the primary ones. Individuals who often have an early age where they become depressed are more likely to develop treatment-resistant depression. Obviously, folks that are actively suicidal have risk factors for treatment-resistant depression. Comorbid psych disorders is also something that's a risk factor. And substance use and anxiety are specific comorbid psychiatric disorders that can have risk, that can be risk factors for TRD. And what's interesting is anxiety, it's very interesting, anxiety and depression are often go together, they're comorbid with each other, but they're also specific, discrete, separate entities. And when we think of anxiety, even though it's not one size fits all, there's different baskets in how we define anxiety. Anxiety can be symptoms that are consistent with OCD, symptoms consistent with GAD, generalized anxiety disorder, symptoms consistent with social anxiety, symptoms consistent with PTSD, symptoms consistent with panic. And so what studies have shown is individuals that have a history of depression as well as a history of anxiety as well as depression are more likely to have that treatment-resistant depression. And what was interesting was the STAR study, which was the largest federally funded study looking at pretty much treatment resistance and the algorithm for treatment, showed that there was, in terms of the characteristics of TRD, there was often individuals were suffering not only from depression but also had that anxiety component as well. So I think that was interesting and really lends support to that there is that not only are they comorbid, but they're exacerbating, having anxiety really can exacerbate depression and can make individuals not responsive to prior meds and become treatment resistant. Further going, individuals with childhood trauma also are more likely to have treatment-resistant depression. We talked about comorbid psychiatric disorders. There's also evidence looking at comorbid medical conditions, specifically cardiac conditions, also can have causality for treatment-resistant depression. Individuals who have recurrent depressive episodes, studies have shown folks that have a history of chronic pain and unemployment are also have risk factors for treatment-resistant depression. Next slide. Okay, so let's talk about those risk factors. Let's talk about someone, individual comes in with major depression is defined by the criteria we started out with. What is the algorithm for treating MDD? And what we often do is start out with an SSRI, and the SSRIs are selective. What that means is selective serotonin reuptake inhibitor, and the SSRIs work mechanistically by increasing the amount of a neurotransmitter serotonin by blocking their reuptake. And the common SSRIs are Prozac, which is fluoxetine, Paxil, paroxetine, Celexa, Lexapro, Zoloft, and Luvox. And within those SSRIs, that class, even though mechanistically they work differently, they work the same, the pharmacokinetics are different. And so, for instance, Prozac or fluoxetine is the most stimulating, it's the most activating. Paxil, on the other hand, is the most sedating. Zoloft is somewhere in between. In terms of how long the medication is in your system, fluoxetine or Prozac has the longest, what we call a half-life. The active metabolite is in your system for about a week. The inactive metabolite is in your system for about 3 weeks. So the good and bad of that is if you're not going to get a withdrawal, if you have taking Prozac and suddenly stop taking it, because literally it'll be in your system for almost a month. The converse to that is if you're not reacting well to that when you first started, there's also a chance that it also will be in your system for some time. On the other hand, Paxil has what we call the shortest half-life, 24 to 48 hours, and it's the most sedating as well. So if an individual is on Paxil, they can stop taking it. There is some concern that there could be a withdrawal effect because of the short half-life. So looking at, besides the different pharmacokinetics, if one is more stimulating and one is more sedating, is there a way that someone comes in that we can predict as clinicians which SSRI for a client to start with? Next slide. And this is really important. Now, that's why I put this as a separate slide. Family history is still the best prognosticator for a medication response. I often get asked about pharmacogenomic testing, and it's exciting. It's something that I think down the road will be really clinically helpful. But I think at this time, and I will sum up, this is exactly from the FDA report, October 31st, 2018, and I think it's worth a read. The FDA is aware of genetic tests that claim results can be used to help physicians identify which antidepressant medications would have increased effectiveness or side effects compared to other antidepressant medications. However, the relationship between DNA variations and the effectiveness of antidepressant medications has never been established. The FDA is aware that healthcare providers may have made inappropriate changes to a patient's medication based on the results from genetic tests that claim to provide information on a personalized dosage or treatment regimens for some antidepressants. Patients and healthcare providers should not make changes to a patient's medication regimen based on the results from genetic tests that claim to predict a patient's response to specific medications, but are not supported by scientific or clinical evidence to support this use, because doing so may put the patient at risk for potentially serious health consequences. So that's from the FDA, October 31st, 2018. Again, I think it's a very exciting pharmacogenomic testing. If there is a way down the road that when an individual comes in, we can have a better sense of what medication may work better, that would be wonderful. And it would hopefully do away with some of the other subsequent need for other trials. So, but right now, this is kind of where we are. Next slide. Okay, so start with an SSRI, either any of those that was in the previous slide, and an individual is not responsive to those SSRIs. What is the next step? Is it switching to another class of medications, or is it augmenting with a medication? And so that's something that has been looked at and examined. Next slide. And answer, jury is still out. There's a JAMA study, Journal of American Medical Association study by Muhammad in 2017 that looked at this. And specifically, they looked at patients who failed initial trials and they were switched to another class of a medication. So they were on an SSRI, they were switched to Wellbutrin, or those patients were augmented with either Wellbutrin or Abilify. This study showed that there was a slight increase in remission with augmenting with Abilify. Abilify is a atypical antipsychotic. Another study also supported this, a 2015 study by Han, supported augmentation as well. These studies, there was support, but it was not robust in terms of the differences. Other studies that have also been out showed that there was no difference between augmenting with another medication or switching. So the jury's still out on that. But let's next slide. Let's start with augmentation. So if an individual, a client or patient is coming in and has failed a first trial, and the provider decides next step would be augmentation, here are our options that there's the most evidence-based for. Lithium, we always think of lithium as a mood stabilizer for bipolar, but lithium also has been shown to help in terms of augmentation for depression. And there's two studies, a Nelson study in 2014 and an Underaga study that showed lithium at doses of 800 to 900 milligrams were superior than placebo in terms of decreasing depression scores. The Underaga study also supported this as well. Another option for augmentation includes atypical antipsychotics. Atypical antipsychotics are medications, as we're aware, Seroquel, Abilify, Zyprexa, Geodon, and a 2015 study looked at this, and they showed that Seroquel and Abilify had the most evidence when augmented with an SSRI to help with episodes of MDD. Third augmentation option is thyroid hormone. And the studies have shown T3 is certainly greater than T4. The thyroid hormone was comparable to lithium augmentation, but also less side effects. Obviously, with lithium, there's a concern you need blood draws, there's tremors, there's several concerning side effects that always accompany lithium. So to have a something that is comparable without the side effects, and the doses were about 20 to 50 units, and that was, very effective as well. And the fourth medication that had the most clinical evidence was Pindolol. Pindolol is a beta blocker, and a Portela 2011 study showed that it also helped when augmented with SSRI decrease in individuals' depression symptoms. I did want to point out that in addition, the last two, the thyroid hormone and the Pindolol, in addition to augmenting for the antidepressive response, another interesting finding was when those medications, thyroid and Pindolol, were added initially or started rather quickly with the SSRI, they also accelerated the response. One of the challenges we all are aware of with SSRIs and antidepressants is they can take upwards from 2 to 4 weeks, generally 3 to 4 weeks. A 2008 study looked at, did a pooled analysis and looked at this and actually showed that citalopram had the quickest response in there, and that was about 7 to 10 days. So to have the ability to not only augment a response, but to accelerate it is something that's obviously very helpful as well. So these are in terms of looking at the augmentation, these are the medications that have the most clinical evidence to support their use. Next slide. Okay, so if an individual is augmented and that is not working, the other option is to switch to another antidepressant class. And when we're talking about other classes, usually we're referring to SNRIs, and that stands for selective norepinephrine reuptake inhibitor. And the SNRIs include medications like Effexor, venlafaxine, Cymbalta, duloxetine, Fatsima, and these medications are also quite helpful, but because of their pharmacokinetics, they can also simulate pseudo-anticholinergic activity, and all that means is it can cause constipation, dry mouth, and some urinary retention as part of their side effects. But they're also quite effective as well. Cymbalta or duloxetine has been shown to help, in addition to depression and anxiety, also with pain. And so it was actually originally brought out for individuals with diabetic peripheral neuropathy, also who had anxiety. So that's one of the features of duloxetine, that in addition to the antidepressant effect, it also can help with pain as well. The other class of antidepressants is the DNRIs, the dopamine norepinephrine reuptake inhibitor. And this medication is Wellbutrin or bupropion. This medication is a fairly stimulating medication. Folks that have anhedonia or low energy or often benefit from this. It has actually several different uses in addition to being used as an antidepressant. It also can be used off-label for ADHD, smoking cessation, and often it's also used to offset the serotonin SSRI induced sexual dysfunction. For the SSRIs, the major side effects as a general class are twofold. They're sexual side effects, and they're also GI effects and the GI gastrointestinal effects. So the individuals who are feeling that they're getting a response from the SSRIs, but sometimes the sexual side effects become a problem, often are augmented with Wellbutrin or bupropion. Okay, next slide. Okay, so I just wanted to go back also to give a little bit of talk on I mentioned the STAR-D trial before, and this was called STAR-D, but it was really the acronym. It's a sequenced treatment alternatives to relieve depression, and it was the largest federally funded trial using antidepressants. They showed that the response rates were about 16 to 17%, and the remission rates were 13 to 14%. And what it was a very structured, large trial looking at kind of an algorithmic approach to treating individuals with MDD. And it was a very important trial. And what, in addition to looking at the response rates, it also was interesting because it also showed that the TRD was associated, kind of supporting what the risk factors on a previous slide was associated with more axis 1 or comorbid conditions such as anxious features than just general MDD. Okay, next slide. So an individual, a client comes in, they try the SSRI, they get augmented, then they try another class. What are some of the other options that we have that are available? And certainly I also want to ensure that this talk is really focused on the medication aspect, but it certainly do not want to minimize the therapy, as studies have shown can be as effective or more so than the pharmacotherapy. So I want to make sure that's really important as well. Just this talk is focusing on the pharmacotherapy and other modalities. So an individual comes in, what are some of the other options that that person would have? And so transcranial magnetic stimulation is a new modality for treating depression, and this gives a kind of a very simple but basic look at what it does. And it's a coil that's pressed up against the scalp, and it has been shown to be quite helpful for treating treatment-resistant depression. So next slide. So actually, how does it work? And it's, in general, what it does is it has an alternating current that passes through a metal coil, which is against the patient or client's scalp. And what this current does is it creates an alternating magnetic field, which then passes through the skull, and that these magnetic fields in turn induce electric currents that depolarize neurons in the surface cortex. And so you're basically creating a magnetic field similar to an fMRI, but instead of the magnetic field being in the whole room as an MRI would be, it's pretty focal and localized. So the focal area that has been shown to be the most effective is the dorsolateral prefrontal cortex. So next slide. So this is an image of where the dorsolateral prefrontal cortex is. This is looking at the left side, and this is the looking at the prefrontal cortex, which you can see is in pink, the dorsolateral prefrontal cortex and orbitofrontal prefrontal cortex, and the ventromedial prefrontal cortex. And again, the studies have shown that the activation on the dorsolateral prefrontal cortex has been the most effective. Next slide. So now that we know what it does, what is the mechanism? Is there a mechanism of action? And the quick answer is it's unknown. But that, there is an unknown mechanism for how lithium works. So that's, there's no specific mechanism of action that's currently available. That's not to say that there's no hypothesis or no studies that have looked into this. Several neuroimaging studies actually support that the TMS stimulation causes increased dopamine and serotonin turnover, and that can lead to the antidepressant effects. There's a paper by George in 2017 that looked at this TMS and did imaging and looked at the increase in dopamine and serotonin turnover from that TMS stimulation. Other hypotheses that the stimulation of the cortex alters the pathologic activity. There's different types of frequency. There's high frequency and low frequency. The high frequency excites the neurons, and that's, again, in the left prefrontal cortex. But there's also data looking at low frequency, which inhibits activity, and that's in the right prefrontal cortex. Next slide. So where someone comes in, are there patients that would not be eligible or where TMS would be contraindicated? And there are. So folks that have unstable medical disorders, folks that have cochlear implants, folks that are at increased risk for seizures, folks that have implanted metallic hardware such as aneurysm clips, and individuals with electrical devices such as pacemakers, all would not be good candidates for TMS. Next slide. And so what is there evidence in terms of for the efficacy of TMS for TRD? And there are, and there's been multiple meta-analysis that's looking at studies, a compilation of studies of both randomized studies, and they found that the TMS was superior to sham treatment, which is placebo, but not as effective as ECT. And I think that's seems to be the general consensus, is that the TMS is more effective than placebo and is very effective, but they're not as effective as ECT. On the other hand, it's much less invasive than ECT as well. Again, this was supported by studies by Slatima in 2010, looking at all the TMS studies, and found that, again, the TMS was greater than the placebo, but less than ECT. And what's also interesting is the traditional TMS is 25 to 30 minutes, but a new type of TMS that involves the intermittent theta burst, which is a 3-minute, also has been shown to be as effective. And a review and a study in Lancet, which is a very well-known journal by Bloomberg and Rodriguez, showed that the in ITBS, a 3-minute was non-inferior, so it was the same effectiveness as the standard for the treatment of depression. So I think that's really kind of the very important study, looking at that folks can get the same efficacy with almost a third of, or more than a third of the time, less of the time. So that's was a very interesting study. Next slide. Okay, so TMS, again, it's a stimulation site is the left dorsal lateral prefrontal cortex. We've kind of had a picture of where that would be to visualize it. Duration, how long is it? It's 5 days a week for 4 to 6 weeks. Both the low and high frequency, although it's used more with high frequency, have shown superiority over sham treatment. Again, from that Lancet article, Lancet review, looked at the intermittent burst and showed that the 3-minute and the standard have the same efficacy. And there's also observational studies looking at efficacy that has been greater than 6 weeks. And there, in terms of, and again, this can be used with or without taking psychotropic medications. The maintenance can also be used after initial time, would be the same protocol as the initial, maybe in a year or 2 years later. Next slide. What are the side effects? So it is the big advantage of TMS is that it's not a medication going through your system. So there is going to be no systemic effects. It's generally very well tolerated, again, which is a big advantage over medications. There is a small risk of seizure. Again, this is 0.1%. So it's 0.001 and 2.5, 0.005. So almost minuscule, but that still is a side effect of the TMS. But there's been studies whether it's not contraindicated, but there is some concern whether it could stimulate a manic episode. There has been some observational studies looking at TMS in individuals with mania that could stimulate a manic episode, headache, and then vasovagal syncope. And vasovagal syncope is very much analogous to if someone has blood, they feel dizzy and can start just feeling perspiring. But again, that's a very minor risk. And so general take home is it's very safe and there's very little risk with the TMS. Next slide. So the other newer modality that I wanted to talk about was ketamine. And ketamine is was approved for intranasal fairly recently, and that's what we'll talk about in the next several slides. So next slide. So ketamine, what is it and how does it work? So ketamine is actually anesthetic that's been used for a number of years. Often, actually, it started as an animal anesthetic, and it's very fast acting. It's widely used. How does it work? It's a non-competitive antagonist of the MDA glutaminergic receptor, but the antidepressant effect is actually postulated to happen through enhancing synaptogenesis. So when individuals are depressed or stressed, there's breakdown in the dendrites in the limbic brain regions, and the hypothesis, or one of the hypotheses, is that the ketamine helps by enhancing those synapses to grow again. And so that's one of the leading thoughts of how it works regarding depression. The onset of action, this is one of the big advantages, is within 1 to 2 hours. And studies actually have showed that it lasts up to a week after one dose. So very quick, and it can last a little bit of time as well. So I also want to describe, when we think of ketamine, I don't want to, not an organic chemistry lecture, but I think it is important to conceptualize when we think of ketamine, what is the difference between S-ketamine, which is what Spravato is, or ARKETAMINE. So it's actually, ketamine itself is what's called a race mixture, and that's really mirror images of one another. Next slide. So this is kind of a good visualization of how we can look at when we think of S-ketamine and ARKETAMINE. So S-ketamine, and if you can look at the NH, they're kind of mirror images of one another. So the S-ketamine is kind of, if you look at the left hand, the ARKETAMINE is looked at in that way. And so those both isomers comprise what we think of as ketamine. Okay, next slide. And so this is from the Jansen protocol, and I wanted to talk a little bit just about what are the dosing and what's the schedule for someone who starts with Spravato. So it starts, there's two phases. There's the induction phase, and then there's a maintenance phase. And then the induction phase is weeks 1 to 4. It occurs twice weekly. The first dose is always 56 milligrams, but then after that, it can go to continue to 56 or 84 milligrams, depending on what the physician feels would be the most help. And then the maintenance is weeks 5 to 8, and that's once weekly, either at the 56 milligram or 84 milligram. And then a week 9 and beyond is 56 or 84, and that's every 2 weeks. And so again, the Spravato is the client or patient themselves administer the medication, and then they're monitored for up to 2 hours. Next slide. So what is the evidence for the efficacy? So we'll look at both the phase 2 and phase 3 studies that have looked at S-ketamine for TRD. The phase 2, just a little bit of background, when we think of phase 2, it's really looking at the effectiveness of a medication, not concentrating on the safety, but looking at purely the effectiveness. And there's been several studies. One of the studies looked at the S-ketamine is IV, not intranasal, just IV, and it actually showed the IV had strong antidepressant effects within 1 hour, and that lasted up to 3 days. Another intranasal study looked at flexible dosing, either 28, 56, or 84 milligram dosing, and they found that response rates were 38, 36, and 50% for that. And that another phase 2 looked at S-ketamine specifically for individuals who were at risk for suicide. And looking at the MADRS score, they found that there was, within this population, there was specifically effectiveness for the risk of suicide with the 84 milligrams bi-weekly for 4 weeks, as measured by the decrease in the depression scale. So these are the phase 2 studies. Let's look at the phase 3. Phase 3 is the studies looking at safety and also confirming efficacy. There's been several. They called it Transform 1, Transform 2, and Transform 3. So one of the studies was clinically meaningful, but did not show significant change in terms of antidepressant scores, and that was with 84 milligrams. That was the Transform 1. The Transform 2 study was a randomized control trial with Spravato added to an antidepressant, and it did show substantial improvements at the MADRS at 28 at both doses, both the 56 and the 84 versus placebo. The Transform 3 looked at, it was a randomized control trial, and it looked at what Spravato was in the elderly population. And it was interesting because as a group for the elderly, it showed that there was no difference. But then when they did a subgroup analysis, it showed actually that there was response from individuals between 65 and 75, but not older than 75. So there was a breakdown. So individuals in terms of elderly between 65 and 75, there was a response, but not over 75. And then another study called the Sustain 1 was looking at individuals who had been stabilized after 16 weeks, and then they were randomized to Spravato or placebo. And the relapse was, showed 26% relapse in Spravato versus 45.3% in the placebo, and that was 52 weeks. Next slide. So what are some of the potential side effects with S-ketamine or Spravato? Dissociation, that's classic. That's what ketamine does. There's some transient cognitive function loss, but no long-term was noted. There was a study looking at long-term functioning, and there was no long-term decline after 1 year. The big ones are the elevated blood pressure and the elevated heart rate, and that's why individuals are needing to be monitored after self-administering the Spravato by clinical providers. There has been evidence that it can increase the blood pressure as well as the heart rate. Other issues are sedation. There is a potential, always obviously with ketamine, for potential for abuse. And then the final was ulcerative cystitis, which is a frequent and painful urination that was rare, but that is still one of the potential side effects for that. Next slide. So what are, just like with TMS, we talked about who would not be a good candidate. What are some of the contraindications for individuals who have, may be interested in Spravato? Individuals that have aneurysmal vascular disease, AV malformation, intracerebral hemorrhage, or hypersensitivity to S-ketamine or ketamine. Those are the contraindications. Often I'm asked if someone has a history of psychosis, are they automatically not eligible? And that is not a contraindication because of there has been studies, and this is why I brought up in the previous slide the difference between S-ketamine and ARKETAMINE. There has been studies showing the difference. S-ketamine may have more of a chance slightly for psychosis than ARKETAMINE, but it is not, individuals that have a history of psychosis, it is not a contraindication that they cannot have Spravato. Next slide. So some of the questions, is it safe for pregnant women to take Spravato? Not recommended. There's not enough human data out there, but there have been animal studies showing that could be potential fetal harm. Is it safe for children? There's been no clinical studies in children that have been conducted looking at this Spravato. And then often after folks come in, they're wondering, is it safe to drive? And there have been 2 studies looking at this. There was a single blind study of 84 milligrams dose, showed that there was no difference versus placebo. And then there was also a double-blind study that showed out of 23 patients, 2 subjects couldn't drive because of Spravato. So, it's jury's still out on that. The first larger study showed that there was no difference. So that's something I think if folks are able to wait, after several hours or monitored, I think it's kind of a case-by-case decision. Next slide. And so I also wanted to quickly before talking about this, I wanted to kind of go back and walk, put a personal touch. So we're presenting kind of the definition, the augmentation, the TMS, and then the Spravato, and it's very exciting, these new modalities, because folks that come in, as I'm sure to our facility, a lot of facilities are coming in that have been on antidepressants in the past. They come in and they're with therapy, with complementary medicine, and then with also these new modalities. Anecdotally, I've seen folks that are coming into our facilities. We do in our facility, we do for the TMS, we do the 3-minute, and we have clients that have gone through it, and the change is just remarkable. And seeing kind of their pre and post, it's really wonderful to see. Anecdotally is similar for the clients that come to see us for Spravato, and they've had so many different trials of antidepressants, and they, it's almost that you can see it on their face. Will this work? And when they do the Spravato, it really is kind of, you can see it in their face, a change and kind of the hope. And I think it's what's interesting and so nice to see is it's not just the symptoms themselves, but that hope that, wow, this is something that has worked finally. And it's really kind of, as a provider, to see that, wow, this is something that folks that are going through all these different trials and have been so feeling things have been so futile, they come in, try these new modalities, and they really have been helpful. So not only kind of do the studies support that, but anecdotally, when folks come in and you can see that on their face, it's really so nice to see. I know we're kind of running low on time, but I did want to just talk very briefly about psilocybin, which is the mushrooms. That's kind of getting into more in the media, and people are becoming very excited about that in terms of how it helps for depression. Again, I want to emphasize there is not FDA approval for psilocybin for depression, but there has been several studies. There is a study by Johns Hopkins looking at the psilocybin in terms of individuals who had cancer and depression, and they showed those individuals really were very improved taking the doses of that with the cancer folks. And then there was another study in Journal of Clinical Psychiatry that looked at 27 patients who had taken the psilocybin and also had shown robust efficacy for that. So I think this is something, another modality that's becoming, people are becoming excited about, but again, not FDA approved at this time. So, I think right now there's, a lot of hope on the horizon where, it's been almost 19 or 20 years since these new modalities for the TMS and Spravato. Before that, it was 19 or 20 years since a new SSRI had come out, a new mechanism. And so this is really hopeful, and really, I think, can really help patients' lives. So I think that's, again, so wonderful to see. I also wanted to mention as well, ECT is certainly a modality, much more invasive and very effective, as we saw from the previous trials, but extremely invasive. You have to induce a seizure, you need an anesthesiologist. So I think the TMS and Spravato for now really are good modalities. Next slide. And I think that's the end of my talk.
Absolutely. Let me give you a couple of the questions. We have a couple minutes left here. We had it scheduled to 12:15, but if people have to leave, in order to get your CE, you'll get the evaluation and do the evaluation, and it will come right there. You had a few great questions. One participant wanted to know what the barriers are to getting a consensual definition of treatment-resistant depression. Like, why can't they come up with a definition?
Yeah, I think that's a great question, and I think that's something that I think you have so many folks having a different view on that, and I think one of the issues or challenges has been specifically, is it more of a kind of binary, either someone has failed or not, or is it more a staging? Is it more kind of on a continuum? So those are kind of some kind of debates that have come up. Another kind of challenge has been how one actually defines whether an adequate response. How many, before figuring out if someone failed it or not, and I think even within that group of figuring out, how do you define an adequate response? So is it 2 weeks? Is it 3 weeks? Is it, did the individual take the med for that time? Were they compliant? So I think there are so many a lot of moving variables in terms of compliance, and that in turn helps define adequacy of response. So I think the answer to that question is, it's a great question, whether it's a continuum, a staging versus definition of how to define adequacy of response, definition of how, finding out if folks, when individuals say they have a failed trial, what does that mean? Did they try it for a full 3 to 4 weeks, or did folks try it a day and then say, oh, I don't feel well? So is that kind of considered a failed trial? So I think all those three variables as examples can have made it particularly challenging to have a general consensus.
That's great. Thank you. And there was a second question about is the potential for abuse. I believe she was talking about the ketamine because she's working with college students who are using the ketamine, but they're using it more for joyrides than healing.
Yeah, so I think that's a great question too. I think the intranasal ketamine has shown, and that's why it's so regulated in terms of that it's used only prescribed by a provider, used specifically under kind of supervision for those either if it's an induction phase 2 weeks, and then so it can't be used kind of at any time. So it's almost a very structured, carefully timed availability of when these individuals can actually be given the medication. And the Janssen also has a REMS program to try to monitor that as well.
Thank you. Well, thank you a lot. There was one other question, but I think I'll just send that one to you, and you can directly respond to that one. It was about the side effects of the Concentra.
Okay.
A little bit off topic for when people are waiting for their gift certificates from Vanna White. Monica, take it over. Thank you, Dr. Shaywitz.
Thank you, Dr. Shaywitz. I'm so honored that I get to follow this. Hello. So we've got some really tough questions, but we've got an amazing lunch. So it's delivered directly to you, either to you and a significant other or to you and your department. So I hope you paid attention because these are really tough. So what type of hat was Dr. Shaywitz wearing during his talk? Can anybody answer that question?
Throw your answer in the chat.
Yay, you got that. No hat. So our winner is Kari. If you can keep track of that for me, Renee, that was she was paying attention. I'm so proud of you, and you can see how tough these are going to be. And let me let you know right now, no business development reps are allowed to answer these tough questions, and you know who you are, Angelina. Okay, second question. So our topic was treatment for treatment-resistant depression. What is the acronym for treatment-resistant depression? Oh, go, look at that. They answered that quicker than they answered that question.
It'll look.
Awesome blossom. And I believe that we have
Nichayam.
Very good. I think we got
probably read that name wrong. Oh, you're going to give one more? Okay.
I think we should just give one more. And
being generous today, folks.
We should make this pretty doggone tough. I think, what is Dr. Shaywitz's first name?
Yay. Amy Walter got it.
Sweet. So please put your information in the chat. If you'd like to have more information regarding our talks, our podcasts, more information about Dr. Shaywitz, we can give you his cell phone, his website. I'm kidding. Did you see him raise his eyebrow for that one? I love it. But we do have WAT events. We have spotlight events. Would love for you to be involved in those. Anyway, put your information in chat. And if you want your information shared, let us know that and we'll include that. Anyway, I'll see you at lunch.
All right. And Overcoming Dyslexia is a book is it an organization? They were asking what is your backdrop.
That was the book Overcoming Dyslexia. That was the book that I was a co-author of with looking at dyslexia and just all about dyslexia, basically.
Absolutely, and it's by Knopf publisher, and it's a really great. And he worked on that with his mother, who is a Yale professor.
Yes, an endowed professor at Yale in pediatrics. So her really has done yeoman stuff with dyslexia, and it was a pleasure to work with her on that book. So
Awesome. Well, we want to thank everyone for coming. Again, save those dates for that February behavioral health conference in LA. And if you know a great speaker, please reach out to me. And we really, from Montero Behavioral Health, thank you for taking time. We know you're busy, and we appreciate the time that you've spent with us. And thank you, Dr. Shaywitz, for this great presentation.
Thank you so much, Renee.